What is fast track surgery? First of all, we are there to know the strong principles our senior surgeons had, that is the preoperative prolonged fasting, mechanical bowel preparation. Nasogastric tubes were thought to be necessary to empty the bowel, to prevent intraoperative contamination, and to prevent early passage of bowel content through an anastomotic suture line while it is healing. Drain tube was believed essential in any GIT surgery. Prolonged bed rests were recommended to facilitate abdominal wall healing. The term fast track surgery was firstly used by Professor Henrik Kellett, who is a gastroenterologist surgeon. What is the aim of fast track surgery? First is the pain-free and stress-free operations, reduced morbidity, enhanced recovery, low rates of organic dysfunction, and reduced need for hospitalization. There is a new regime called fast track regime, that is controlling the post-op period as well as to improve the outcome. We have to pre-inform the patient, then we have to attenuate the stress, pain should be relieved, enteral nutrition should be given and mobilized as early as possible. The members involved in ERA's program are nurses, dietitians, physiotherapists, pain team, anesthetists, surgeons, and hospital management. This is the fast track surgery components. It includes pre-admission counseling, pre-operative things we have to follow, then the anesthesia, type of anesthesia, surgical approach, and post-op activities which are used to enhance the recovery. In the pre-admission counseling, we have to clearly explain what is to be happen during a hospitalization to the patient, explanation of the role of the patient about food intake, oral nutrition supplements, and mobilization after surgery. Preoperatively, we have to assess and optimize the organ function, seeks to reduce operative risk, alcohol and smoking cessation for a month. Bowel preparation leads to patient discomfort, dehydration, electrolyte imbalance, and is no longer recommended in elective abdominal surgery. Modern fasting guidelines recommend that duration of preoperative fasting should be 2 hours for liquids and 6 hours for solids. Preoperative nutrition and good carbohydrate diet reduces the post-op thirst, hunger, anxiety, and significantly reduce post-op insulin resistance. Intraoperatively, we have to give fluid therapy to avoid sodium and fluid overload. Goal-directed fluid therapy via esophageal Doppler monitoring. Fluid overload is associated with delayed gut function and increased complication rates. Maintenance of normothermia is important for preventing sympathetic responses, cardiac arrhythmias, and wound complications, as well as tubes and drains. There is no routine use of drains or nasogastric tubes. Then anesthesia. Epidural, spinal, or peripheral nerve block remains a key element of fast track program and has been associated with attenuated endocrine stress response, increased gut motility, reduced inflammatory response, and optimum pain relief, but its application must be procedure specific. For example, for lap colectomy, spinal analgesia or patient controlled analgesia may be superior to epidural analgesia within a fast track program. Short acting opioids are commonly used in fast track surgery in combination with regional anesthetic techniques to minimize the amount of anesthetics used and to facilitate recovery. Then the intraop surgeries. We have to be very precise about minimal invasive techniques, short transverse incisions, laparoscopic, reduce in patient stays, lessen morbidity, and lower post-op pain. First of all, oxygen therapy, that is, it may reduce the risk of wound infection and anastomotic complications. Antimicrobial prophylaxis is recommended to prevent infectious complications, and anticoagulants minimizes the thromboembolic events. Then we come to post-op activities. Post-operatively, we have to encourage oral intake as early as possible to facilitate early return of bowel function, aids mobilization, leads to faster recovery, reduces post-op morbidity, and is not associated with an increased risk of anastomotic dehiscence. Early removal of nasogastric tube and drain and catheters are used. Early mobilization is recommended, as well as for post-op pain, opioids, NSAIDs, epidural anesthesia, as well as local infiltration of anesthesia are used. We have to prevent post-op nausea, vomiting and ileus, because these are unpleasant and delays the gut functions, affects mobility and has metabolic consequences. Give prophylactic antiemetics, that is ondansetron, during anesthesia around 30 minutes before the end of the surgery. Ileus can be avoided by early mobilization, laxatives and electrolyte balance. Then we come to discharge criteria. Patient can be discharged when they meet the following criteria, that is good pain control, taking solid foods, independently mobilized, as well as willing to go home. Is fast track surgery safe and effective? Evidence from clinical trials as well as expert opinions of surgeons in the field suggests that fast track programs can result in benefit outcomes of the patients. In particular, optimizing conditions before, during and after surgery can reduce the length of hospital stay for patients with no increase in readmission rates, morbidity and mortality. The available evidence suggests that fast track protocols are as safe and effective as conventional treatment regimes. In what surgeries we can apply fast track surgery? First of all, colorectal surgeries, bariatric surgery, liver and pancreatic resections, breast surgery, urological procedures, as well as orthopedic operations like hip and knee replacements. This is the curve we are following during the fast track surgery, that is after fast track surgery. As we follow fast track surgery, patient, there is lessen pain and as well as increase the recovery and lessens the morbidity. Enhanced recovery after surgery saves money, resources, time with no increased complication rates. Thank you.